Hey, good morning. I'm Dr. Stephen Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dulles Simons Family Studio. Delighted to be back with you on this warm, toasty Wednesday morning. Welcome to Open Mics with Dr. Stites. You can find me here every Wednesday talking about all things COVID, and someday if COVID will finally relent because we've all been vaccinated and wear our masks appropriately, we're going to be doing some deep dives and some other cool topics. But today, and for unfortunately the foreseeable future, we are focusing on how COVID is wreaking havoc with our communities, our health systems, just kind of our lives in general. Today we have several guests joining us to talk about the impact COVID is having, especially on emergency rooms. In studio with me today is Dr. Chad Cannon, Chair and Clinical Service Chief of the Emergency Medicine Department, and Dr. Ryan Jacobson, EMS Physician Advisor and Medical Director of Johnson County Emergency Medical Services. We'll talk more about what you're seeing every day, but we're gonna check in just a moment with Dr. Dana Hawkinson. I think Hawk may be dropping his kids off at school today. He's going to be right here, and he's going to go through the inpatient numbers. I'm going to hope they get better between where they are right now and the time he arrives, because right now they're a little depressing. But we're going to talk about that more in just a moment. I'm going to talk first to see if there are any reporter questions that are on the line.
Sure. Good morning. Cody Holyoke with KMBC 9 News.
Hey, Cody.
Hi. Big breaking news from Johnson & Johnson this morning. They say that they have a study that's soon to be published that found that a booster of their shot 6 months after the first dose increased COVID protection by 900%. Now, again, the data isn't published yet, but I'm curious your take on what does this mean for the vaccine push?
Yeah, you bet. I did see that, and yeah, they say it boosts their antibody levels 8 or 9 fold, which is similar to what we're seeing with Moderna and Pfizer data. So I think it shouldn't surprise any of us that a booster is going to give you a better effect. You know, the reason to give a booster is to make sure your antibodies stay revved up at a high level. There is some emerging data that suggests that antibody levels do kind of track with infection. You think, well, of course that's true. And it feels obvious, but it's not necessarily obvious because vaccines induce multiple different forms of immunity. It's not clear if those other forms wane, but it does appear to be more clear, though, that as antibody levels fell, that patients became less immune, and that's why we're seeing some of these, quote, breakthrough infections. And so as a result, I think it's encouraging news that J&J gets a great booster response. It's just like the Pfizer and Moderna data. I think J&J will have the same booster recommendations at probably around 6 or 8 months, just like Moderna and Pfizer are going to have. And that's probably what we're going to do. And I bet we're going to settle into an annual pattern of booster shots. We won't know that because we've got to see how long this new booster lasts with any one of these any one of these classes of vaccination. So let me summarize that. So first, boosters are a way of kind of reacquainting your immune system and stimulating it to make sure the antibody levels stay high, and you do that when there's a very high prevalence of a disease in the community, as there is with COVID-19 right now. We can give boosters, by the way, with influenza vaccination to accomplish the same thing. There are some patients who are immunocompromised and who, if they get their influenza vaccine in September, may need a booster in February. And so not an uncommon idea. The difference is, influenza tends to fade out, and we don't have to worry about it anymore after about March or April. And so you get basically a 6-month period without it, so you get a new influenza shot every year. What happens with COVID-19 is that it stays prevalent in the community. The variants come about, and you need that booster to make sure you have all the defense you can need. And that's why you're going to see it with Moderna, Pfizer, and now the evidence is about J&J. Now, we've not reviewed that evidence. They did talk about a fairly small number of patients they tracked out of their volunteers. I think the number I saw today was like 7 volunteers that stayed in the study, and they were tracking their levels. And that gave them the signal they need to go back and look at other volunteers, and then they gave them all booster shots. That data should be coming out today. There's kind of a preprint version that's going to hit one of the websites. People can take a look at it. Obviously, they're going to be submitting that to the FDA, and I suspect they'll be included in the boosters just like others have. And then we'll have to just track all the side effects, just like we do with Moderna and Pfizer vaccine. So I think not surprising. The good news is that all the J&J, Moderna, and Pfizer all continue to offer really strong protection, even at 6, 7, 8 months, against severe hospitalization, which I'm going to define as having to come into the ICU, or death. And so I think that's really important. So even though the vaccinated patients are being hospitalized, they rarely progress to severe illness or death. And when you look at the population of vaccinated patients who are being hospitalized, most of them are very immunocompromised right from the start, so it's not a surprise to us that that's happening. So I think it's good news about J&J. I think it will likely become, they'll likely require a booster of the J&J vaccine probably around 8 months, just as we are with Pfizer and Moderna. And I think the overall activities of all three of these vaccines to protect against severe hospitalization and death is outstanding.
Gotcha. Another big story that broke after yesterday's briefing, Missouri's Attorney General and Senate candidate Eric Schmidt had filed a class action lawsuit working to block school districts in Missouri from imposing masking rules. What's your take? What are the difficulties you foresee from a medical side if this suit goes Schmidt's way?
Yeah, I just hate when politics gets into healthcare. So I'm going to stay in my lane here as best as I can. Interesting observation, because the state of Oregon just said you had to wear masks outdoors again. And so they're on the other end of this, right? And what they're saying is we should go back to where we were, whereas if you can maintain your physical distance, you're out walking in Lewis Park in the morning, there's nobody around you, don't worry about it. But if you're in a crowded setting, like you're at a sporting event or something like that, then you need to wear masks. And I think that's a different view than what we're hearing from the Attorney General for the state of Missouri. And I think he's trying to say, gosh, individual rights trump the requirement for masks. Hopefully he's not doubting the science, because the science is extremely clear and it's compelling around the importance of the Delta variant. And what we're seeing is that there's widespread community transmission. What we're worried about is that by not wearing masks, kids who are now having to be hospitalized and are dying from the Delta variant, children will become much more infected. There are so few of them are vaccinated. And what that will then do ultimately is will close the school, because the schools will have widespread infection. Remember that the Delta variant spreads in 2 to 4 minutes, not in 8 to 12 minutes. And one person can infect up to 8 or 9 other people because it's so transmissible. And so if you think about that dynamic, it is so much worse than the original strain. We kept schools open last year by masking and dedensifying, and what we're now saying is the kids are going to come back full force, even though the Delta variant is highly transmissible throughout our community, a high rate of community transmission, and I guess we're just going to use hope as our primary reason that we think schools are going to stay open. I think that's bad for kids. I think it's bad for our community, all from a healthcare standpoint, because I think you're almost guaranteeing that those schools are going to end up having to significantly quarantine vast numbers of their kids or even close down. And I think that's just the wrong attitude. So from my standpoint, as a healthcare provider, again, I'm not in front of the parents and the families and trying to understand all the politics of it, but from a pure healthcare standpoint and infection disease standpoint, I think what we're doing is opening up schools without masking means you're going to open up schools to closing. And that just seems wrong to me as a healthcare provider, not to mention you're going to put kids at risk, you're going to put students at risk, or teachers at risk, and then those kids are going to go back home and they're going to spread the disease within their homes. So I think that's going to especially affect vulnerable communities, which means where there's a low rate of vaccination. And by and large, there are a lot of counties in Missouri and a lot of areas in Missouri where there's a very low rate of vaccination. So to me, it's just not a good health strategy, and I guess I'm just surprised. But I'm not a politician. I can't answer that question politically. But I think from an infectious disease standpoint, there's really no question about what the real answer is.
Sure. Thank you.
Other questions?
Dr.
Just, I know some folks that sent questions in.
They have. I actually have several, so I'm going to get to these.
You bet.
Carolina at KCTV5 is asking if the doctors can comment on your thoughts about parents and guardians having the authority to sign medical exemption waivers for their kids and masks at school.
Yeah, so Hawk's not here yet, but what I can see, that question's come up a couple of times, and here's what I would say. That's a parental exemption. It's not a medical exemption. Let's just be clear. And if the school wants to make that they have all the rights to do that, I guess. But it's kind of like when you're as a parent, you sign the form that says my kid doesn't have to, do exit school, or hurt his whatever the exact, can't go on the field trip because I don't like where they're going or whatever. I think those are parental exemptions, and saying that your child doesn't have to wear a mask is a parental exemption. It's not a medical exemption. That should come from a medical provider. And obviously we do that a lot for kids in schools. And I think to be honest, let's just call it and say it what it is. It's just a way to make it easier for kids not to have to wear masks. And going back to the question from Cody, I think we just invite more infectious disease challenges when we do that, and we make it more likely that schools won't be able to stay open, which from a psychosocial standpoint seems to be about the worst thing we can do for kids.
Katie with the Kansas City Star has a question. With the KDHE adding the January 9, 2020 death to its dashboard, making it the first reported COVID death in the U.S., according to the CDC, what does that say about the presence of COVID in Kansas? And are COVID deaths likely underreported, especially those from the beginning of the pandemic when testing was not widely available?
Yeah, I think that's probably right. I think when we didn't have a lot of testing, we didn't understand the disease. A lot of people probably died from that we didn't track because we just didn't know. And I think it's become increasingly clear that COVID was circulating in the United States before what we thought. And so I don't think I think that's right. And it reminds me, again, I often reference I've been a doctor approximately a very long time. We won't say exactly how many years because I'm not sure I can count that high. And if you go back to HIV, there are a lot of HIV deaths that didn't get accounted for because we couldn't diagnose this, we didn't want to diagnose it, and we didn't have all the testing available for it. And so now the HIV deaths were probably a lot higher, was probably out there a lot longer than we knew, and I suspect the same is going to be true for COVID-19, and someday we'll be smart enough to go back and figure all that out. But right now, I think it's safe to say that COVID-19 was probably in the United States before December, and it probably did take lives. And I think that overall, the COVID-19 deaths are underreported. There's this ongoing controversy, right, about whether a death is COVID-19 or the death is lung disease, and emphysema or asthma. And the problem is that when you have a disease like COVID-19, as with any infection, it will make worse your underlying disease. Now, again, that's true for any infection. I can have a standard pneumococcal pneumonia, which is called the community-acquired pneumonia. Well, did I die of my pneumonia, or did I die because I have such severe emphysema I couldn't breathe with that pneumonia? Well, the reality is we say pneumonia is the cause of death, and a contributing condition is your underlying lung disease. I think that's how we answer all these darn forms that all of us fill out, and you guys fill out. I'm talking to my ED colleagues too, because they have to fill these out when patients die in the emergency room. You try and go with what you think the main diagnosis is, and then you talk about the things that also led to that death. But I think people are dying of COVID with their other diseases. It's just when you have those other diseases, you don't have a lot of reserve. Without a lot of reserve, you can't fight it off very well, and that infection disease is going to get you a little sooner. Hey, Jess, you're muted.
Sorry about that. Okay,
No,
so
I do it
Bianca
every day.
with KMVC has a couple of comments and then a question. She said that she read about a report about insurance companies phasing out COVID-19 cost-sharing waivers. Also, that the KCMO Health Department recently shared the average cost of a hospital stay for a young person with COVID to be about $51,000. So looking to hear from our health system about the cost of COVID-19 care and how that might change now that the vaccines are widely available, and of course with the Pfizer vaccine having FDA approval.
Yeah, well, vaccines are a whole lot cheaper than hospitalization. There's no question about that. Those vaccines are free to everybody, and the mRNA ones are turned out to be pretty cheap to produce. So I think there's no question what a massive difference there is in the cost. But that's probably true about most preventive health strategies. The average cost of pick your prevention, getting your blood pressure checked is a lot easier than getting hospitalized with a bleed or some problems related to high blood pressure. So I think that clearly that's the case. As far as the issues around waivers and reimbursement, I would have to get our folks, we probably need to get Colette back on the program, Jess, and we should earmark that, have her come back. She really runs a lot of our patient billing and things like that, and she's much smarter about those kind of areas than I am. but I'm pretty darn smart about how cheap vaccines are compared to the cost of a hospital stay. There's just not there's not too many ways about that.
Okay. Thank you for that. Dr. Stites, Shane with KCTV5 has a question about something you touched on, which was the Johnson & Johnson reporting that the booster shot increases antibodies about 8 or 9 times. What is your reaction to that, if you could just go over that again? And would you be recommending the J&J booster for your patients?
Yeah, so great question. So the evidence, yes, I think it's really important. I think we all need to look at it carefully, and then we need to look at the evidence, not just from what right now we're just working off the press release from the company, and we can't really make policy on that. But I don't think it should surprise any of us that the J&J as a one-shot dose does a lot better when you get a 2 or 3 shot dose. And so I think that what we're going to see is that series of boosters is going to help. I think it's great news. I do think that people with J&J if you just sit tight for another week or two, I suspect you're going to start hearing the same chatter we've heard around Moderna and Pfizer, and that eventually we're going to be recommending boosters for J&J patients as well. And I think that'll be really good news and offer more protection. Just as an aside, I think the other really interesting question out there that's under study that we don't know the answer to yet is whether or not you're better off staying with the same vaccine or mixing and matching. So if you've gotten the J&J first, should your booster be an mRNA like Pfizer or Moderna, or vice versa? If you got the Pfizer Moderna vaccine, should you switch Pfizer Moderna vaccines for your booster? Should you use the J&J for your booster? Those studies are ongoing. I don't think we know the evidence to that yet. Right now, the FDA is recommending staying with whatever your initial vaccination was. I suspect that'll be the policy for the next few months until the data that comes out from some national and international studies around this question is available.
Dr. Stites, I have one more question. This one's from Rebecca at KMBZ, and I would like you to bring in our guest to answer this question. But first, I have a video I want you to watch. Take a look at this. This is called the Milk Crate Challenge.
Okay, the Milk Crate Challenge. So these are not Chiefs highlights or watching Mahomes throw the ball down the field 100 yards or out of the stadium. No. Okay, Milk Crate Challenge. Got it. I notice they're hands-free. Oh, okay, this does not look safe to me.
Yeah, you should have seen the one we had pulled up. This guy completely came crashing down. I mean, it looked like he busted his back right in half. So, ow.
Okay.
Yeah, ow. I think I know
that just can't be right.
Yeah, what are your thoughts?
Well, I'm just going to look at to the chair of our emergency room, Chad.
Please don't do that. I've seen that video and other videos like that, that you're at risk for falling and hitting your head and getting a head bleed. You're breaking your neck and becoming paralyzed. When you fall, you naturally will extend your arm to try to catch yourself. You can break the bones in your wrist. I think this is just a silly thing that folks are doing because
it looks stupid.
It's just stupid.
I mean, come on. You land on the milk crate, you will break your back and be paralyzed. Oh my God, Ryan.
Yeah, if you watch these videos, which I unfortunately watched yesterday, these seem to be typical peer pressure fueled challenges where people are egging people on to do this. And I agree with Chad. These are super high-risk activities, and when you watch the position that people land in, I see spinal cord injuries, head injuries, orthopedic injuries, and it seems like a simple challenge that people are egging people on to do, but at the end of the day, that simple challenge, it seems like a fun TikTok thing to do. Might end up in the ICU, might end up in the ER, might have an incredible healthcare cost.
Yeah, maybe end up in your grave. Yeah. So can I just say, vaccines clearly prevent serious illness and death from COVID-19. Being in a drunken stupor and taking this challenge is not a preventive health strategy. It will not prevent serious illness and death when you land on a milk crate and split your back in half. This is a bad idea.
Hey, Dr. Stites.
Yes.
Can Dr. Jacobson and Dr. Cannon just kind of comment, though, on when we are in the middle of a surge like this and we have very, very busy ER staff, when people are out doing stupid stuff like this, just the strain it puts on our emergency departments. Can you
let's just transition. Let's transition to that part of the conversation. But before we do that, just really quick, Hawkeye, how are we doing today?
Hi. A lot better than those people doing that
milk crate challenge. Yeah, that's dumb.
So the numbers at the hospital are not good at all.
They're not good, are they?
They keep climbing.
I go out of town and all of a sudden you're skyrocketing. Well, I can't go out of town. I think that's the message.
We need your voice back here so we can
Okay, I'm here to cause
get it out
trouble.
to the masses. 66 active infections right now here in the hospital with 26 ICU patients. 14 ventilators are being used of those 28 ICU patients, or 26 ICU patients, I'm sorry. Of the total 66 active infections in the hospital, 8 are vaccinated, so 12%. One time last week we were down to 2% and then 6%. We have 12%. We seem to hang out about that. That
5 to 10% level is kind of where we are.
Yep.
Yeah.
Which is, I think, it's a little bit lower than, or it's a little bit higher than the national average. We still see the majority of those people are unvaccinated. So of those 66 active infections, we still have 33 additional recovered patients as well, so a total of 99 patients. And would like to point out also those vaccinated patients, one of them end-stage liver disease, 2 of them are solid organ transplant, others active chemotherapy, lung disease, diabetes, so have significant comorbidities.
And probably never had a good vaccine response. I mean, that's really the key. These are probably the group of people we're going to end up giving a 3rd shot to right away, I bet.
Correct, and a couple of those, in the of our ICU patients, of our 26 ICU patients, 2 of those are vaccinated. So one is a transplant, very immunosuppressed, and the other has significant cancer comorbidity as well. Yeah. Also, Hayes has a total of 10 patients. All of those are active right now.
We saw the numbers from children still really high, 16 overall, which is a big number for them. And once again, showing that kids are getting sick, so bad idea to not have children in masks at school, kind of like taking the milk crate challenge. Why would you really try and do that? And all of that makes our emergency rooms really crowded. So how is life down in the ER?
The emergency department's very busy. We have about 55 beds in our ER. I looked this morning, and we're already starting off with almost all those beds already full. Typically, we would maybe only have half our beds full, and as the day goes along, the patients come in, the beds fill up. But we're starting off with our beds already full, so as the day goes along now, during the pandemic, they start piling up into our hallways, into our waiting rooms, and we can't get patients then out of our ER into the hospital because the hospital's full. And so it's a very tough situation for everybody.
So this gurney thing, people coming in on gurneys and they have to sit and wait. I mean, how long are people waiting on gurneys, just from ambulances even?
It varies. Often patients are waiting in the waiting room for several hours. Once a patient is treated by the physicians and seen and we determine their cause, if they need to be admitted, then they often will then have to wait several more hours, sometimes up to 6 to 10 more hours to be admitted to the hospital bed. Some patients, when there's no beds available at all, are waiting over a day in the hospital, in the ED to be hospitalized.
So I'm in a drunken stupor and I have the need for having personal challenges and personal victories. I decide to take a milk crate to climb and see if that does not make me feel like a better, stronger person. And in so doing, I fall. I can't move my arms and legs anymore. Is that going to make it harder for you to take care of me? Because that's kind of what we call a time-sensitive diagnosis.
Yes and no. It depends. If you just fall off the milk crate and you break your arm, you're often going to be triaged at a lower rating, and you're going to wait behind folks who are coming in with sicker conditions, who can't breathe, who have low oxygen levels, who may be having heart attacks or strokes. You may wait 12 hours to get your arm evaluated, treated, and set. Now, if you fall off and unfortunately have a head injury or spinal cord and you're paralyzed, you will be triaged higher and seen right away. But as you can imagine, that was very preventable, and you're taking resources away from folks who can't control their condition and who may be having a heart attack or stroke, despite they're not making a poor choice. And so this is just silly and contributing to additional frustration by all.
So we say don't drink and drive. Maybe the next rule is, sorry, I pounded the desk there. Don't drink and climb. Okay, Ryan. So you work on this question every day. How do we get patients around the community? I mean, you're the head of Johnson County and you're also one of our ER docs. How challenging is it right now just for the ambulance crews to find a place to take our patients? And you and I were talking a little bit before we started this morning. Talk to us about that story.
So it's a huge issue. All of the hospital EDs in the entire region are having the same experience that we are here at KU. And I talk to ED directors and ED docs from all the community hospitals on a routine basis, and they're at capacity. meaning not only are they at inpatient capacity, but that trickles down to the ED to where the ED is at capacity. And it's been all the time for the last couple of months. We have had record-breaking levels of what we previously called diversion, where ambulances are being diverted or EDs are announcing to the ambulance crews, we're functionally kind of behaving like we're closed to ambulance traffic. We call that high volume. And last night when I was working in ED, 12 hospitals in the metropolitan area were forced into a status of being open, because 12 hospitals, which is over half of the metro hospitals, had a capacity issue in their EDs. So hallway beds are a real thing in all the hospital EDs across the region. We call it wall time, which is the time that the EMS crew has to sit on the wall with their patient on the EMS cot before we can find a bed. And there are places around the country and in the Midwest that have hours of wall time, where the EMS crew brings the patient in and they sit on the cot for hours because they can't find a bed. Locally in our region, we don't have hours of wall time, but we have had 30-minute, 45-minute wall times in the region locally in Kansas City, where our EMS crews arrive and we can't find a bed in a local ED because there's no physical bed space or staff to care for that patient and do the transition from the paramedic to the inpatient staff in the ED. So it's a regional conundrum, because all the EDs are at capacity, and it's every single day. Last night we had 6 stroke centers and STEMI centers that were on diversion for time critical diagnosis. We had 2 trauma centers last night that were on diversion for trauma. So that shuttles the time and critical diagnosis to the open centers, and that cascade effect of multiple close, and then all the strokes go to one center, and multiple, then they close, and it's just kind of a waterfall effect. Incredibly challenging.
And before the program started today, we were talking a little bit about what is the role of patient autonomy in here, because we know that patients will say, I'm a KU guy, right? Obviously I'm a KU guy, and so I want to get my care. But an ambulance came for me, I'm like, take me to KU. My wall time or my maybe high, I still want to go to KU. I mean, do patients get much say in that?
They do, and that's actually what's triggering this afternoon meeting with the Healthcare Alliance to talk about community ambulance diversion at 3:30 this afternoon. Is we do value patient autonomy. When you call 911, like we always kind of joke, we're not in the kidnapping business. We need to work with you about where you want to go. We can't just hijack you and take you to somewhere that you don't want to go. So we involve the patient, and if they have decision-making capacity, they have the ability to make that decision and say, I'd like to go to this hospital. It might be an insurance issue. They have a payer that demands that they go to that facility. They may work there. They may be a staff member there. They may be in their community they're visiting, but all their family lives in that community, and all their health care is in that community. And so they may be visiting Olathe, but they get their care at Providence or get their care at KU. So they say, well, I want to go to where my health care is. So we value that, but at the same time, we've got all the hospital EDs telling the ambulance crews, hey, we're full. Like, if you can go somewhere else, there's a 6-hour wait. We're full. We don't have any beds in our ER. So the ambulance crew is put in a continual conundrum of trying to explain to the patient, we understand you broke your hip, you want to go to the healthcare provider that you have chosen, but the consequence of that is you might be sitting in the waiting room, or you might be sitting on a bed in the hallway for a long period of time because they're overwhelmed. And we have to have those awkward discussions driving down I-35 or 69 highway with a patient who's having chest pain, say, well, my cardiologist is at St. Joe, and St. Joe's saying, well, we're closed, or Menora's on diversion, or OPR. All the hospitals are equally involved in this kind of process. It's a real challenge. So we do value autonomy, but we also have to make sure our ambulances stay in service for the community. So if all of our ambulances are bunched up at a hospital with wait times to get off the cot of 30, 40 minutes, we stack our ambulances and they can't respond to 911 calls. So it's a balance of autonomy versus system status and maintaining ambulance availability in the community. Super hard job. Super hard.
This is really a difficult thing, hard. And I think, and it's got to affect just the morale of the ambulance communities as well.
Absolutely.
COVID-19 must have exacerbated this because there's just so many more patients in hospital beds right now.
Yeah, we have a paramedic shortage nationally. EMS is in a very big staffing crunch, similar to nursing. And you can understand when you're out in a 100-degree day on the highway taking care of somebody on the asphalt, and you're sweating, you're carrying all of your heavy equipment, you're lifting patients off the ground, you're doing all this work to assess them and get them somewhere, and then you call the hospital on the radio, and they say, we don't have room for him. And then they call another hospital. We don't have room for him. Call another hospital. We don't have room for him. Sometimes 3 or 4 phone calls, and we've had those instances just this week where ambulances are being diverted multiple times trying to find a home for the patient in the region. That's really frustrating.
Well, and it is, especially with these time-sensitive diagnoses. If you're standing in somebody's house, you know they're having a heart attack, they're gone down, you resuscitated them. You've got, I mean, every second counts. And if you're on the phone making calls, those are just seconds that you're losing, right? That's just tough.
And you're asking EMS to make a decision. Do you take them to a place, it might be a specialty center, who's got a staff crunch, bed capacity issue? What is the balance between taking them to a place that's a little bit slower, that may be more peripheral, but isn't a resource center for time-sensitive interventions? So you
Right.
have to balance, like, well, the ED's available and they can resuscitate, but they're going to have to transfer that patient. And, transferring is really hard right now.
That's really hard.
Really hard.
That's really hard. So how's that affect the morale down the ED, Chad? What's it like down there?
The morale has evolved during this pandemic. Initially, there was a lot of unknowns, and the volumes are actually down, but that anxiety and the unknowns created a lot of, just folks were scared and made it frustrating. The volume slowed down. Now we understand the science. We feel safe in the ED when we're working. But now that the surge is happening again, and we have a vaccine that can prevent this surge from happening, our staff are getting tired, and they're wondering, this is preventable. If we take our vaccine, we wouldn't have this surge, and we could take care of the patients that need to be in our ER that don't have a choice.
Are folks angry?
I would say, at the individual patient, no. We treat every patient. We don't judge you when you come in our emergency department. We do listen. I had a patient last week that chose not to get vaccinated, was very sick, was going to the ICU, and they wept and cried, and they said, I can't believe I made this choice of not getting the vaccine, and what it's going to do to my family, and who's going to take care of my family. And, I empathize with the patient, and I'm hoping this patient recovers and gets better and goes out and educates others to not make the same choice they did. But unfortunately, some patients don't get a second chance. So it's very hard to see that when you have a choice to get a vaccine that can prevent this escalation of the disease and prevent death.
Yeah, and I'm going to say it, I'm sorry, but the International Society of Internet News, ISIS, is really not a good source of journalistic news, nor is it a good source of science. And it just strikes me, Hawkeye. People continue to believe the internet, but they don't want to believe these wide published studies from really reliable sources of people trying to do the right thing.
Yeah.
Really? TikTok versus the New England Journal of Medicine. Let me think about it again. Let me say it again.
Yeah.
TikTok against the CDC. I just don't understand it. I don't get it.
It is really amazing. And like Chad said, individually, we are going to take care of you, and we are going to put all the effort that we can to getting you better. But the overall umbrella is frustrating. We are how many months into this pandemic now? How many months into available vaccination? And we still have people saying, I wish I would have gotten the vaccine, so I'm not ill, and I'm not in the ICU, and I'm not leaving my kids parentless. So this is going on still, unfortunately, and I can't fathom exactly why. But I think a lot of it is social media. There are a lot of political reasons. There are just a lot of reasons why people still are making excuses that they don't understand why this happened, and they wish they would have gotten the vaccine.
Yeah, you just got to stop the lies. You got to stop the delusions. You got to listen to the science, because we're really not here to try and make it up, folks. And the problem is that once it hits you and you realize it wasn't really a hoax, then it's too late.
Yep.
And those are the people who are dying. And remember, the vaccinated patients, they're not dying, right? They're not the ones who are dying. It's the people who are unvaccinated who account for 90% of our hospitalizations and 98% of the deaths. And the folks who are vaccinated, you know what, who die, that's because you didn't get a good enough immune response. We're going to fix that. We're going to get you more shots in the long run. But right now, you bang your head on the wall. The greatest healthcare challenge of our times, society's closing up again, we're having a mask again, all because people don't want to get vaccinated. And you have to get vaccinated with all this other stuff. But somehow the COVID-19 vaccine has become the wrong thing politically, and I don't get it.
Yeah, or
it's dumb.
I think it is politically driven, and now there are people who don't believe the CDC, the FDA, and I think that's fine as long as your thoughts and feelings are consistent. don't go to the physician then when you have cancer or you have a urinary tract infection or a sinus infection. At least be consistent in your thoughts, and you're picking and choosing, cherry picking items or headlines that you just don't want to believe, and it's a major hypocrisy as well.
Jess, are there any other reporter questions? We're done. I'm done ranting for the moment. It may come back, though. It may come back. But are there other reporter questions or questions from our community we should pick?
No reporter questions, but I do have some good community questions if we can jump into those. And the first one is from Sandy, and she was hoping our ED docs could clarify the effects of long wall time for those paramedics. If paramedics are sitting with their patients in wall time, how is their availability to respond to other calls, or is this just another problem we're having?
Ryan, that is the problem, isn't it?
That's the challenge. There are places in the Midwest, not in our region, fortunately, other medical director peers of mine who have 3 and 4 hour wall times where ambulances are in the ED, unable to transition care because there's no space. We don't have that problem here regionally yet. We're hoping we don't get to that point, but we do have some elongated wall times, which we've noticed.
But what's a normal? What should a good wall time be? 1 minute?
Well, no,
1 minute.
no,
Yeah.
no wall time. Yeah,
Right.
Usually
We're here. Let's go.
Historically, we come in with a patient, we notify the ED ahead of time, and they have a bed waiting for us. Or sometimes we can get the patient off the cot and walk them, and they can go to triage and go to the waiting room for minor injury and illness. I think the best thing that the community can do to kind of help offload that, if you will, is reserve 911 for emergencies. And I think, sometimes we do get folks who, chronic issues. If you have access to primary care, if you have a very minor illness or injury, and you have alternative means of transportation, I think it's reasonable to save the 911 system for the true emergencies, the strokes, the heart attacks, the trauma victims, the car accidents, the folks that break their ankle so badly they can't walk, it's pointing the wrong direction. That's when you need your ambulance. But the minor stuff, I think we're to a point where our system's so saturated, we want to use emergency services appropriately. So I think that's a message too that the community can help with. Don't call 911 just for a ride.
Yeah, that's tough. And Chad has got to frustrate the teams down in the emergency room because they don't want to have to make those patients wait on the wall either.
That's correct. And we're really not seeing a lot of, I would say, abuse of EMS for injuries that are mild, but every little bit helps. What's really contributing to this problem is folks not getting vaccinated. And I looked at our hours of when we're on high volume of diversion and the curves of how many hours in our city that is going on. It actually mirrors the surge of COVID. And you could lay those two graphs on top of each other and they're the same exact shape. So we need time to catch up. And if folks get vaccinated, the curve will bend and come down. Our EMS volumes will go down, and we can get back to taking care of patients, and EMS can get back to doing their job, and I think we're going to be in a better place. Yeah,
it's interesting because you think we're pretty used to the ebb and flow of disease in the United States, and you actually, years ago, hospital and communities used to be really what we would call overbedded. They had more beds than needed. And it was because you could build a hospital kind of anytime you wanted to, and then these certificate of needs came about. It became harder to do that, and then all those extra beds cost hospitals a lot of money because they still have to maintain them and do whatever. And so we have a much tighter relationship between the supply and demand in hospital worlds over the last decade or whatever. And I think what we're seeing is that COVID has made the demand so much higher that suddenly we're out of beds. And initially in this pandemic, the bed crisis wasn't as severe. There was still a bed crisis, but it wasn't this severe. And that was because we saw a drop in people coming in for other diagnoses, whether it be heart attacks and trauma, et cetera, and the infectious diseases were way down. Once masks came off and society opened up, man, all the infections came back, all the behaviors came back, people were doing all the same things they already did, and we stopped seeing people wait too long to come in with a heart attack and stroke and cancer, and all of a sudden all the numbers were high. So the hospitals were really full in this area before this wave of COVID. And now we got the COVID wave on top of that, and that just made everything a lot worse again. So we're just out of beds. All right, Jess.
Okay, so one viewer has a question, a comment about this being about science and masking. Please share your studies that have been done on masks and how they work, because studies done at Oxford University have said differently.
Yeah, that's just not true.
No,
I'm sorry, it's just not true. So here's the simple reality, and we've said this so many times, Hawkeye.
Yep.
What is the rate of transmission
Yep.
inside our hospital on our COVID units of staff taking care directly of people with COVID-19 and especially the Delta variant? And the rate is, it's almost zero. And why is that? Because people are masked.
Yeah, we're not going to share every little study about this. The majority of the consistent, well-done data and studies show that masking in those situations, especially those high-risk situations, indoors, crowded spaces, poor ventilation, do reduce the risk of transmission. There are studies recently from the MMWR looking at air ventilation and masking in schools in Georgia, and actually showed a 30 to 40% reduction in incidence rate of COVID when you have those. Again, nothing is a single a panacea. So it is masking, it's distancing, it's ventilation, all of those things. There are certainly studies that would show something else, but you have to ask, what is that study asking? And just because they found something, does that mean that that is significant? And what is the context of that study? This came out, 6 or 9 months ago? There was a study, and there were a lot of people who were taking some of the data, some of the numbers out of context, and they were saying masks don't work as well. But again, understand, what is that study asking? How was it performed? What are the caveats of that study? And what are the contexts of those numbers that we're looking at that? So again, to reiterate, the majority of the consistent evidence shows that masking in those especially high-risk situations does work to reduce the incidence of the spread of SARS-CoV-2. We even have Donna Ginther from University of Kansas now has published at least 2 articles looking specifically at Kansas, showing the good impact of masking in stopping the spread of disease in Kansas.
There's just no real question about it. We
Yeah,
know infection control works, and we bent the curve when we did masking before. We can bend it again. People just got to commit to it. It's a pretty simple act. We're talking about the cost of a hospitalization. Masks are cheap, vaccines are cheap.
I don't know how on August 25th, 2021, we're still having this debate.
Yeah, why are we still fighting about masks? That's ridiculous. And plus, just to say, inside hospitals, we've known for generations, decades, the importance of masking as a measure of infection control for all sorts of infections, whether it's really bad staff, or it's in the operating room, or wherever. I mean, masking clearly makes a difference. Do you think masking works, Chad Cannon?
Well, we have 30 physicians in our ED, 10 advanced practice providers, 75 nurses and techs. I'm not aware of one of them, despite taking care of a dozen of COVID patients, who've actually acquired COVID from the patient in the ED. The handful of folks who've actually come down with COVID, they've all looked back and they've realized they've got it from their significant other in the house, their child, or a friend when they were out in the community. So
we're just not seeing it. Because otherwise our numbers would be ridiculously high.
To me, that's better than any study.
Yeah, I think so. That's what I'm saying.
It's a year of evidence.
The evidence is found in every single hospital in America where people are masks on their COVID wards. I mean, it's just, it's overwhelming. That's why it's just so hard to swallow. People still saying masking doesn't work. Oh, yeah, okay, well, whatever. Sorry. Yeah, it does.
Nancy and Jenny have similar questions. If one would like to get the J&J vaccine, where could I get one? And if you got the J&J months ago, can I get the Pfizer or Moderna as a booster?
Yeah, that's a great question. And Hawkeye, these are hard. You saw the J&J study out today saying, look, man, we can really have a great booster effect when we give one in 6 months. Yeah. I think it's too early yet. We haven't seen that data. It's not published. We want to review it ourselves. It's so consistent with what we would expect from vaccine theory anyway that I think it'll end up being true. But so far, I don't think we're, under the early use authorization, we're not allowed to give a J&J booster per se.
Right. Yeah, under the guidance and authorization, just as you said, it's one dose right now. They do have these new reports out that we still need to look at, and they show boost in antibodies, which again is not surprising. We know that once you get an antigen load, such as what's given in the vaccine, you will have a boost in antibodies and stuff like that. So, yeah, I mean, I think a lot of people were waiting and really wanted some information. Those people, especially that got the Johnson & Johnson vaccine, kind of left out a little bit. But we also understand Johnson & Johnson vaccine was authorized a little bit later, so there is less time frame there, and now we're going to be starting to see that. And I think the big question will be, should we do mixed or heterologous dosing? So that means two different vaccines, the Johnson & Johnson plus an mRNA vaccine. The mixed dosing, we don't have a lot of information like that. We do have some information about AstraZeneca and Pfizer from the UK, but again, we don't use AstraZeneca here. So I think there will be guidance, and ultimately, will everybody be receiving a third dose or more dosing anyways, and whether that's with the same platform vaccine, the mRNAs, or the Johnson & Johnson adenoviral vector vaccine, or are we going to be using mixed things? And just as you had stated earlier, those are questions we just don't have answers to right now.
Do we have time for a couple more questions, Dr. Stites?
Let's ask two quick ones.
Okay, so just your comment on this. Ann says yesterday a friend of hers read a quote from a military leader, not a medical expert, who argues that the vaccine should not be mandated for military because most are young and healthy, and there's just a tiny chance of dying from COVID-19, and the vaccine has side effects. I told her he is not a medical expert and does not know what he's talking about. What are your comments?
Well, I think the military is moving to require vaccination of the entire military. So obviously, most of the military leaders believe that it should, because remember, the military also is really important to be able to man up and go wherever you need, or to be ready to deploy. And if half your platoon's out with COVID-19, whether you're dead or not, you can't be deployed. And so I think the military's made a very clear decision that they're going to vaccinate all of their members. So I think that's the right thing to do. I think you're going to see more and more of that go across the country. I think that's something, you'll stay tuned. We'll see how the health system policy evolves here over the next few days, and we'll learn more about that. But I think we're all going to be requiring mandatory vaccinations, just as we do for influenza and other things. And again, as far as side effects go, the side effects of this vaccine are minimal. Very, very, very few deaths. Most of them have been reported either with J&J or AstraZeneca from vaccine-induced thrombotic thrombocytopenia, which is where your platelet count drops, and then you end up with these funny clots. And fortunately, that looks to be treatable now in about 2/3 to 70% of the cases. And the overall rate of clotting with the J&J vaccine is far less than with COVID-19. So I think at the end of the day, we're going to assume that this will become more and more mandated throughout different organizations, including the military. I personally think, Hawkeye, right thing to do.
Yeah, we certainly need those brave servicemen and women to protect us. We need our police to protect us, our fire departments, our EMS, to be able to provide those services and protect us. And just hearing that comment, certainly would respect that military leader, but it is also somewhat of a myopic opinion there. COVID-19 is not just about death. It is about being able to be healthy and not sick, either at home and isolated for 10 or 14 days, or being sick enough to go to the hospital. And so when we can use vaccination, we know and we have shown that vaccination does reduce overall the spectrum of disease for COVID-19, and especially going to the hospital and having severe disease. So it is not just a question of death, it is a question of keeping people protected and healthy so that they can continue to work and serve.
Yeah, and I think that's right, and not to mention the long haul syndrome. Jess.
Okay, so this will be the last question. A lot of good questions that I'll hold on for follow-up Friday. So this one goes from Cindy. With Mosaic in St. Joe and also Cox and Mercy in Springfield announcing that they are requiring vaccination for their staff, the question is, when will KU make that decision? Where are we at with that?
Yeah, great question. I'm not at liberty to discuss it too much. It's kind of an HR thing, but I just stay tuned. I think we'll be talking about it more over in the next few days. All right, let's try and go around the horn here and get some final thoughts. Hawkeye, I'm going to start with you.
Yeah. Good news, I think, for those people that did get Johnson & Johnson vaccine. Good news from that company, it sounds like, and what we can do and just further add protection. We are still learning more, and there are a lot of new reports out that maybe support some new guidance that will be coming through with additional dosing for not only immunosuppressed patients, but the rest of the population as well. But again, just take comfort in understanding that even all of these reports, a recent one from MMWR from the CDC publication, I think yesterday or 2 days ago, looking at infection, symptomatic infection, but all of these continue to give protection against hospitalization, severe disease, and death. And those are always the stories we see. Those are what Dr. Cannon was talking about when people come in and they're so ill because they didn't get the vaccine. These vaccines continue to provide great protection and protecting you from having to go to the hospital, severe disease and death. So please go get vaccinated. And when more information comes out about Johnson & Johnson and other dosing, we'll certainly let you know.
Chad, final thoughts?
You know, as I said earlier, emergency departments in the region in our hospital are very busy. EMS is busy. I think COVID-19 is also just about, it's not about just yourself. It's about thinking about your community and your family. Please get vaccinated to help us allow us to catch up and to take care of patients who are making the right decisions, who may have a disease state that even if they did get vaccinated, they still need our care. And I really ask the community just to heed that advice and get vaccinated so we can catch up and take care of your loved ones.
Right.
I would say, just to echo what Dr. Cannon said, I would say just please be patient and have grace as far as when you're dealing with emergency responders, ED staff, or healthcare workers. It's a hard job right now for everybody, and I think there's a lot of emotional drain going on in the region due to capacity, understaffing, whether it's EMS or nursing and other healthcare providers. So I would just say, please be patient with us as we work through this. We're trying our best. There are a lot of very smart people trying to tackle these problems, and we're continuing to work on it. And we hope to have more solutions, but appreciate the patience.
Hey, thanks for being with us today. I want to thank these guys for coming down here. And Chad came in at the last moment. I think he was up in the ER probably taking care of somebody. So want to be just let you all know how much we appreciate all the great work our ER does every day. I sent a patient in yesterday, got great care. I think I sent a patient in a few days ago, they got great care. And despite the overwhelming nature of COVID and healthcare today. I want to thank all of our audience for being. I'll be back here tomorrow on the Morning Medical Update with Hawkeye, Jess, and we'll hear from 3 other chief medical officers in their hospitals about what they're doing around this COVID spike. And before we go to our closing, we have a really cool closing video here. I just want to ask you all a thought. At what price delusion? At what price are you willing to pay for your health when it comes to wanting to listen to ideas that may play more to your personal belief system but run counter to the best medical advice? We're not here to mislead you or to delude you. We're not here to spin a story that isn't true. Our motivation, and the motivation that all 4 of us swore to go into medicine with our oath, is to help take care of you. At what price are you willing to pay to not hear that story, but rather to spin a story that is not based in science? It is both darkening and it's just so lonely to hear that story that you had, Chad, about the patient who was so embarrassed as they lay unable to breathe, being admitted, going to the ICU, not knowing they'll live or die, and say, I'm so embarrassed I didn't get vaccinated. When 98% of the patients in the hospital who are dying are unvaccinated, why is the choice so hard? Let's take a look at this video.
I mean, it's affecting everyone.
This past wave has definitely felt a little bit different. The patients seem to be a little bit sicker than what we've seen before. All the treatments we're doing, sometimes it just doesn't feel like it's enough.
Sometimes it happens so quickly, there's not even time, and we call family after it's done. The worst thing ever is being a family member for someone that can have their family member present at the end. And watching that final goodbye, knowing that they might not come off the ventilator.
I think it's been emotionally draining for everybody up here, because no one wants to see anybody go through that.
Saying, I'm sorry, I wish we wouldn't have gone on this trip, or I wish we wouldn't have done this, and I love you.
But I just hold their hand, and I tell them that I'm there with them, and the family's on Zoom with me, and they're alone, but they have all of us up here.
Good morning, Stephanie. Is this a good time to come in and pray?
So this time around, we do have people that say, wow, I wish I would have gotten the vaccine. People that have come in with no medical conditions really, and if they had only gotten the vaccine, the outcome might have been different.
Holy and gracious God, we come before you this morning to ask your blessing.
You can see it in people's eyes even, in their tone of voice as they're trying to breathe.
Take good care of this good man.
So I hear a lot of regret from patients, that they hadn't taken it more seriously.
In Jesus' name, amen.
A lot of the very, very sick people that we have up here have not received their vaccine. So I would say definitely get your vaccine.
So hopefully we can all take a step back and realize it's not just about me or you, it's about everybody.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.